How does patient racial discrimination affect the quality of healthcare received? I have chosen to do my research on the question, how does patient racial discrimination affect the quality of healthcare received? Patient treatment seems to be poor for some patients due to racial discrimination regardless of age. The disparities between healthcare quality and race seem to be caused by various elements. Patients of minority races receive different levels and quality of care regardless of their socioeconomic status. This topic is important as it is a major social problem that is affecting our health, morbidity rate, and mortality rate. If the healthcare quality was to improve, it would have to start with changing the process and ideals of our healthcare system. I think this study can be beneficial to the field of sociology in that uncovering the magnitude of patient racial discrimination may bring heightened awareness and put an urgency onto the need for a solution in order to help patients to be able to seek out treatment and receive fair and equal health care regardless of their skin color. In a study by Peek, Wagner, Tagg, Baker, and Chin, it was found that the minority races receive lower quality health care than whites in the treatment of many important clinical conditions regardless of their insurance. The conditions of patients' clinical status were not different from each other, which would otherwise account for some of the disparity. Patients that were over the age of 18 were selected at random and were administered surveys that asked questions in regards to their healthcare experiences within the past 12 months. The questions included questions about personal treatment, medications, follow-up, self-care education, and health outcomes. It was reported that the lack of quality in healthcare has impacted minority groups by increasing the number of morbidity and mortality rates. It was also found that the racial and ethnic discrimination in healthcare produced less preventive care, less prescription medication use, less medical testing and treatment, which also resulted in less patient satisfaction. According to a study by Savine, Riviera, and Greenwald, healthcare provider bias, stereotyping, and clinical uncertainty in interpersonal patient interaction may contribute to healthcare disparities. The study was conducted by assessing 20-minute anonymous web surveys. The Race Attitude IAT test was given to pediatric faculty, fellows, and residents from one department at an urban research university. The test included questions about physician knowledge, attitudes towards patients, quality of medical care, and association strength tests. It was found that the majority of test takers, which were pediatricians, showed less implicit preference for white Americans relative to African Americans, then had over 1 million self-identified medical doctors that had previously taken the test and tested to have more implicit preference for white Americans than for African American patients. It is thought that maybe the training of the physicians and life experiences to other characteristics may have contributed to the low amount of implicit bias that was found in the results of the test. The third study by Stepanikova was conducted to find the potential for racial bias due to physician perceptions of patients and time pressure. The study was conducted on 81 randomly selected physicians that were licensed with the American Medical Association in order to have physicians with the same level of education and credentials. They were given a timed web-based test that consisted of medical cases involving a patient of specific ethnicity or race. This test measured the way in which the physician perceived the patient and the treatment given based on the limited amount of time that was given to them for the patient care. It was found that medical judgment was affected by the patient's ethnicity and race, but only under high time pressure. The physicians seemed to pursue more aggressively the treatment of white patients with considerable magnitude than African American patients when they were under the stress of time. The probability of referrals to specialists was a lot higher for white patients than for African American patients when under high time pressure. Aside from the physician's perception of the patients, minority patients received lower quality of care overall. In another study by Gray, Schlesinger, Siegfried, and Horowitz, racial and ethnic disparities in healthcare were present even when socioeconomic differences, health insurance status, and other access-related factors were adjusted for. The study was done to find the extent of disparity in race and healthcare treatment given at high-volume hospitals for specific treatments that were volume-sensitive services such as cancers and cardiovascular procedures. The study was conducted by researching patient discharge records from New York Statewide Planning and Research Cooperative System for short-term general hospitals, veterans hospitals, and long-term care units of short-term hospitals. All patients were over the age of 18, except for pediatric cardiac surgeries, which only included patients less than 8 years of age. The data researched included clinical information as well as the patient's insurance, address, proximity to hospital, and hospital use. It was found that whites were twice as much more likely than African Americans to use high-volume hospitals. Hispanics and Asians were less likely to use them than whites, but the disparity between Hispanics, Asians, and whites was still significantly smaller than that of whites and African Americans. Minorities are possibly less likely to use high-volume hospitals due to the low quality of care received. The last study that I researched by Jacobs, Corman, Lemon, and Vickers indicated that the disparities between race, ethnicity, and healthcare quality is a highly known fact in the healthcare industry. This disparity has been a major impediment to improving healthcare in many communities in our country. The study was done to see the benefits of implementing physician training on how to address racial disparities in health. Physician training is conducted by the West Side Health Authority with the collaboration of a large public hospital in the city of Chicago. In this case, they used Cook County Hospital. The goal is to give physicians understanding and the tools to have better communication and provide better care to African American patients. This training would increase the physician's awareness of the patient's lives and how to build relationships with them. The curriculum is meant to teach the physicians on how socioeconomic and insurance status impacts the health and healthcare of disadvantaged groups. To improve cross-cultural understanding and communication, it's meant to increase appreciation of the complexity of the patient's lives and how it impacts on their healthcare and the ability to access healthcare. And it is also meant to enhance physicians' awareness of the capacity of community and local services to impact positively on patients' well-being in a long-term sense. The research method used for this study was a 15-question survey that was conducted in written form in order to address the question, how does patient racial discrimination affect the quality of healthcare received? Surveys are a cost-effective way to gather information from a large sample of people. Although my sample was not large and only consisted of 11 people, I felt that using a survey was the best research methodology for my research question. A preliminary selection process that I used was to ask random people if they had recently received healthcare services. I gave questionnaires to 11 random people who had received healthcare services within the last 6 months. The people that were chosen for the survey were of different ethnic backgrounds, genders, and socioeconomic status. Their ages ranged between 22 years old and 61 years old. The random participants were asked if they would like to participate in the research questionnaire. Upon their agreement to participate, they were briefed on why I was conducting the study, what my research was focusing on, and I gave them a summary of my findings through the peer-reviewed journals in order to give them a little understanding on the topic. This research was done by asking the questions regarding some type of healthcare facilities, the type of healthcare facilities sought in order to receive medical care during general health issues, urgent care illnesses, and emergency care illnesses. Some questions reference the patient-doctor relationship, personal views on the quality of healthcare received, and views on the relationship between their healthcare quality and their long-term health outcomes. The responses were recorded by the participants by checking off short answers or writing a short answer on a line for each question. For my participants, I had 36% of them were males and 64% were females. 37% of my participants were Hispanic, 27% were African American, another 27% were Caucasian, and 9% were Asian. In regards to the results for the questions on what type of medical facilities are sought for general healthcare services, urgent care services, and emergency care services, the findings were as follows. For general healthcare services, the Hispanic participants stated that they would see their primary care doctor. So did the African American participants, the Caucasian participants, and the Asian participants. For general healthcare services, they tended to prefer to go to the primary care physician or primary care medical group to take care of low-level illnesses or ailments. For urgent care services, the Hispanic participants stated that majority were seeking aid through the urgent care clinics, and few of them would go to the hospital for urgent care services, but neither of them would go to the primary care doctor for services for urgent care. The African American participants preferred pretty much equally to go to urgent care clinics or to hospitals for urgent care services, but they also did not go to their primary care doctor to seek services for their urgent care illnesses. The Caucasian participants seemed to prefer to go to urgent care clinics in order to be seen for urgent care illnesses, and the Asian participants did not go to any hospitals or urgent care clinics for urgent care services. They actually wanted to see their primary care doctor for any urgent care necessary treatment. For emergency care services, Hispanics seem to go to the hospital, as well as the African American participants, the Caucasian participants, and the Asian participants. No one wanted to see a primary care doctor, and no one preferred to go to urgent care clinics in order to treat any emergency care illnesses or ailments. All of the races and all of the participants preferred to frequent a hospital when they had an emergency care issue that needed attention. On the questions that pertain to healthcare satisfaction, I rated in a scale from 1 to 10 for them to choose how much satisfaction they had in their primary care physician or their healthcare services in general. For the Hispanic participants, out of a 10-point scale, they chose a 7. For the African American participants, out of a 10-point scale, they chose a 4. For the Caucasian participants, out of a 10-point scale, they chose an 8. For the Asian participants, out of a 10-point scale, they chose a 5. So the Caucasian participants seem to have more satisfaction in the quality of healthcare that they are receiving, regardless of whether it's a primary care physician, an urgent care clinic, or a hospital. The Hispanic group was less satisfied than the Caucasian group, but seemed to still have a pretty high selection as far as points for their healthcare satisfaction. They did choose a 7, and the Asian group was the next participant group that shows one of the highest ratings. For them, it was a 5, mainly because sometimes from their notes they feel that they are having to seek treatment in hospitals or in urgent care clinics due to more often than not, their primary care doctor is not available at the hours that they need treatment. If it is an emergency or an urgent care matter and it is late hours of the night, they obviously won't find their primary family doctor's offices open at those times. So they feel that the attention that they get at hospitals or at urgent care clinics is subpar compared to the treatment that they get with their primary physician. But overall, they're not too happy with their healthcare service, but they're not too disappointed in it as well. It's kind of like in the middle. They feel like it could improve, but it's not as bad as it could be. For African American survey takers, they actually ranked a 4. According to the participants, some of the comments that were made from them in regards to healthcare satisfaction and quality was that some of them did not have a primary care physician because they felt that they would get better care at urgent care facilities or at hospitals where they take urgent care patients, or at hospitals for emergency care, basically because they feel that they don't have to worry about the one-on-one patient-doctor relationship. To them, it feels like having services at a hospital or at an urgent care clinic is a little more diverse, so they feel a little less stigmatized when they see a physician that is at a high-level hospital, rather than going to a particular doctor or family doctor, where they feel a little more stigmatized and possibly a little more racialized when it comes to their treatment. The Hispanic group did not necessarily complain much about discriminatory problems, but more than anything, the timing in which they had to wait, the wait time to see a primary doctor, or the wait time to get urgent care or to be treated at a hospital, they sit and wait for quite a few hours. So that was more than anything the complaint. But the Caucasian group seemed to have the highest rating as far as quality satisfaction. And the reasons that they gave were not necessarily quality of treatment in a one-to-one basis, or in lack of referrals or lack of prescriptions. It was more kind of also a time management thing, where the doctor would write prescriptions and then when they have to go pick them up, they're not ready, or they do have to wait long amounts of times to see their particular doctor, or if they do have to go to an urgent care clinic or a hospital, it's also the wait times. You don't get to make an appointment, or you don't get to be seen right away. It's always some kind of a setback or a long wait time. So for the most part, according to my findings, I seem to notice that they do correlate quite a bit with the findings from the previous research that I did, where there does seem to be more of a level of satisfaction with Caucasian and Hispanic survey takers, and more Caucasian survey takers than any other race, possibly because they don't have any complaints of any type of impersonal treatment or anything like that. Whereas for the minority groups, there was a little bit of a complaint about the treatment and the way that it felt to go to a primary doctor, and how that personally makes them feel, where it seems like it's a little bit of a biased situation. This research was very beneficial to my understanding of my research question. I found that most of the data for my research did correlate with the findings of the other research that I read in the peer-reviewed journals. It was interesting to see people's opinions firsthand and to be able to see how people feel about the topic of racial bias in the healthcare system. I do think that it was interesting to see how people feel about their own personal medical care and what their perception is on the quality of healthcare that they receive from their primary medical groups, given their race. Since many of our communities in San Bernardino County are comprised of low-income families and minority groups, it is evident that low-quality healthcare is caused by racial discrimination, has a large impact on the long-term health of many of our citizens. Some of my survey takers actually did mention that they did not do follow-up very often. They pretty much took their prescription and went home and took their medication and pretty much let the illness ride it out, and let the illness kind of, just dissipate with time, just in order to avoid the uncomfortable feeling of having to go back or having to wait long hours again, or having to, fight the time to sit there and wait to be seen for a checkup again with the doctor to follow up on the treatment. So, luckily, with this research that I did, there are some things that are being implemented, but hopefully there is further research that is conducted that can lead us to really put some kind of a stop to, or, some kind of a fix to the racial bias that exists in our healthcare system currently. Thank you for watching my presentation. Have a good day.